Greetings, everyone, and welcome to the EKG case for the week of September 8th, 2014. This week's case is coming from our own shop right here at the University of Maryland Medical Center, and this case was taken care of by a couple of my colleagues, Drs. Samara Tuweld, Dr. Angela Smedley, and senior resident, just about to graduate, Dr. Laura Olivieri. This is a really fantastic case during a night shift, and I came in on the morning shift after they were packing up the patient to send the patient up to the intensive care unit. And I'm just going to start out with the 12-lead EKG. Take a look at it. We'll get into the history in a little bit, but take a look at this 12-lead EKG. Hit the pause button if you need to. There's probably enough on this 12-lead to come up with a diagnosis. There's a wide complex tachycardia, obviously, and the heart rate is 190. Look carefully at it. And if this is all you had, and you didn't have any other clinical information except maybe the patient's unconscious, what would you do with this 12-lead? Anyway, let's actually get a little bit of history about what happened with this case. So paramedics arrived in the pre-hospital arena for what was presumed to be a patient found down. And when they arrived, the patient was actually having a generalized tonic-clonic seizure. So they gave the patient a quick dose of midazolam, and it may have helped a little bit, but then they got a 12-lead, or at least a rhythm strip, and they noticed a wide complex tachycardia. This is not their rhythm strip or their EKG, but pretty much this is what they saw. Just pretend that all they saw maybe was the wide complex tachycardia. Well, no surprise, they decided to shock the patient, not once, but twice, because the first shock didn't work. He had a decreased level of consciousness, he's got a wide complex tachycardia, and maybe he had a borderline blood pressure. He definitely was not hypertensive. I think his blood pressure was, as they say, pretty soft. Systolic blood pressure was maybe about 100, 110 at best, and so very appropriately they decided to shock the patient, and it didn't do a whole lot of good. In fact, the patient went right into asystole after the couple of shocks. They did some good chest compressions for probably, as I understand, less than a minute, and they got his pulses back, and he resumed his wide complex tachycardia, and they just got this patient to the emergency department within a few minutes. And when he arrived to see my colleagues, he was still unconscious and had this wide complex tachycardia. He was barely arousable, and his blood pressure was still relatively borderline, maybe around 100 or so. So they secured his airway with quick rapid sequence intubation and got bilateral IVs and did all the usual ABCs and resuscitation things, put him on a monitor, and we don't really care about that. At the moment, we care about the 12-lead EKG, right? After all, this is a 12-lead EKG video series, not a large bore IV video series. For those people that are interested in that, you're going to have to do a little Google search for those videos. But anyway, here's the 12-lead EKG, and you've taken a look at it already, and there's a few things that we'll talk a little bit more about in detail over the next few slides. So first of all, of course, it's a wide complex tachycardia. Overall, it looks fairly regular, so, I'm not really thinking about atrial fibrillation. But one of the things that you notice is that there's a little bit of irregularity in the morphologies. Now, there's not tremendous morphology, and normally if I tell you that there's a wide complex tachycardia and the morphologies are changing, maybe the first thing that pops into your head, hopefully, is atrial fibrillation with WPW. But this really doesn't look like atrial fibrillation. There's just some slight variation in the morphologies up there, which maybe makes you doubt ventricular tachycardia just a little bit. And VTAC, of course, should be the first thing that comes to mind. And then you start thinking about some of the other things that can produce a wide QRS set of complexes. So, of course, here's a differential for wide QRSs. Whenever you see wide QRSs, whenever I do, I just stop for a second and think about what are the things that can give you a wide QRS. So VTAC, that's of course the first thing you're going to think about. Anytime you put ventricular tachycardia or ventricular ectopy, you of course are going to include paced beats. So pacemakers can make that QRS wide. Bundle branch block can make the QRS wide. WPW can widen the QRS. And then there's a few non-specific causes of interventricular conduction delay. Severe LVH can produce wide QRS complexes. Really bad cardiomyopathies, bad meaning they've got a really low EF, ejection fraction, and end-stage cardiomyopathies can oftentimes produce an interventricular conduction delay. End-stage cardiomyopathies just screw up everything, including the conduction system, so they'll develop a bit of a non-specific conduction delay. And the way I think about non-specific conduction delay is that it's a wide QRS, but none of these apply. So you just call it a non-specific conduction delay. And the other couple things to remember in emergency medicine, people outside EM may not have to think about these as much, but certainly in the emergency department, you're always going to think about medication toxicities, those sodium channel blocker overdoses. We've talked about things like cocaine overdose, which is a type of sodium channel blocker, and metabolic problems. Most importantly, hyperkalemia. Severe acidosis can give you wide QRSs also, but medications and metabolic things are things that we as emergency physicians definitely have to think about and are not really addressed all that much in other specialties, and not even in ACLS. So one of the other things that you may notice about this particular tachycardia is that it's not just a wide complex tachycardia, it's a really wide complex tachycardia. And that's also something that we've talked about before, not in quite some time though. And one of the points that I had made in previous videos is that when the QRS complexes are really wide, we're talking about more than 200 milliseconds. In other words, the QRS complexes are greater than one full box wide, right? More than 200 milliseconds. And it might not be that obvious in all of the leads, but I think down in V1, you can, let me get rid of some of this. In V1, you can appreciate just how wide those QRS complexes are, maybe out here in V6 and maybe in V5, but in some of the leads, you really appreciate that these are really, really ginormously wide QRS complexes. And when you see QRS complexes that are wider than 200 milliseconds, wider than than one big box, that's not really normal for VTAC. It's possible, but it's not the norm for VTAC. VTAC usually doesn't get that wide. And so you need to think about some of the other things that in the differential that we've talked about. In particular, think about medication toxicity, sodium channel blocker toxicity, and think about metabolic problems like hyperkalemia. All right, so let me say that one more time. Whenever you encounter really wide complex tachycardias, then things that should rise in your differential and rise to your level of consciousness should be medication toxicity and metabolic problems, especially hyperkalemia. Now, this patient got shocks. And shocks probably aren't going to do a whole lot for those medication toxicities or hyperkalemia. They probably won't hurt, but they're not going to help. You may consider giving calcium and bicarb early whenever you're thinking about hyper-K or medication type of problems or metabolic problems. After all, if you give calcium to somebody who's hyperkalemic, you're going to save a life. If you give calcium and it turns out that they're not hyperkalemic, it's really not going to hurt. And probably the same thing applies to sodium bicarb. If you give sodium bicarb to somebody who's hyperkalemic or has a metabolic acidosis or has a sodium channel blocker overdose, bicarb may save a life. And if it turns out that they don't have hyper-K or a medication toxicity, and you give 1 or 2 amps of sodium bicarb, it's really not going to hurt. It'll be metabolized very quickly. What about ventricular antiarrhythmics, lidocaine, amio, or procainamide? Well, here's the problem. Those are oftentimes touted as your first-line therapies for people who have relatively stable, wide complex tachycardias. But the problem is that if the patient has hyperkalemia, which is a sodium channel poisoned state, or if the patient has a sodium channel blocker toxicity, and now you give them more sodium channel blocker, for example, lidocaine, amiodarone, or procainamide, you may just kill the patient. So when in doubt, when you encounter that really wide QRS tachycardia, why not just try some calcium bicarb? And if you're right, if it turns out to be hyper-K or metabolic or a sodium channel blocker toxicity, you will see the QRS narrow right before your eyes and you just saved a life. Whereas if you go with ACLS and jump right into these medications, you're going to kill somebody. And again, what's the first law of medicine? Primum no killum, right? Okay, so let's move forward. Back to this really wide complex tachycardia. Samara was managing the arrhythmia while Angela and Laura were managing the airway primarily, and Samara actually 2 years ago, I guess, finished our emergency cardiology fellowship, and she's now lecturing and doing a lot of teaching in emergency cardiology. So when she saw this EKG, she knew that you've got to worry about medication toxicity, you got to worry about hyperkalemia. And so she went right to the bicarb. Now, you couldn't fault anyone if they wanted to try some calcium first, and maybe I would have thrown some calcium in here also. Although, you know what, if this is hyperkalemia and acidosis usually will produce wide QRS complexes and maybe tachycardic, although hyperkalemia and severe metabolic acidosis, when they produce severely wide QRS complexes, they tend to be a little bit more slow rates. I mean, this rate is 190. Hyperkalemia does not usually produce tachycardias of this magnitude, maybe 100, 110, 120 or so, but not this fast. And so I think going right to bicarb is very, very reasonable. And of course, it is just a little bit too wide, in my opinion, for VTAC. So the first thing that I'm going to do is exactly what Samara did. We'll go with bicarb. In fact, she was aggressive with the bicarb. After 1 or 2 doses, she started seeing the QRS narrow. So she said 1 or 2 is not enough. She gave 5 amps of sodium bicarbonate, and take a look at what ends up happening. Miraculously, the P waves reappear. This is sinus tachycardia, and the QRS narrows down, and you've got your diagnosis. This is probably a sodium channel blocker state. If this were hyperkalemia, you might see the QRSs narrow also, but you'd probably see more peaking of the T waves. Those are just maybe a little bit peaked, but I'm not sure that's enough that I would call it hyperkalemia. The other thing that's suggesting that maybe this is a sodium channel blocker overdose is, we talked about this before, there's a rightward axis, and there's also a tall R wave in AVR, both of which are very common with sodium channel blocker toxicity. You get that rightward shift of the axis. Well, a little bit while later, they did find out that this patient had intentionally overdosed on tricyclic antidepressants that he was on in an attempt to kill himself. And so what they ended up doing was just giving more bicarb. They put him on a bicarb drip, and they ended up using a lipid emulsion infusion. All right. So quick take-home points for tricyclic overdose. This is a great case and a tremendous save. Always consider tricyclic overdose or sodium channel blocker toxicity in patients that have tachycardia with seizures. In the past, we've talked about how arrhythmias can produce seizures. Brugada syndrome, when they go into the VTAC or VFib, that can produce seizures because they hypoperfuse the brain. Long QT patients develop torsade that hypoperfuses the brain, and that can produce seizures, and so on. But of course, if somebody's tachycardic with seizures, one of the other conditions you've got to think about is tricyclics or other sodium channel blocker conditions. So tachycardia plus seizure, it could be an arrhythmia, but it could also simply be the tricyclic overdose. All right, what do you look for on the 12-lead EKG for tricyclics? Rightward axis, classic, and that's a great board's pearl to keep in mind. Rightward axis with tachycardia on your board exam, think either PE or tricyclic overdose. You got your tachycardia. PEs won't produce the wide QRS. Tricyclics and sodium channel blocker toxicity will. And oftentimes you get that tall R wave in AVR, which is also typical of tricyclics and not PE. All right. So rightward axis. Let me go over that one more time. Classic EKG findings for sodium channel blocker toxicity, TCAs being the classic. Rightward axis, tachycardia is almost universally present. You will often get a tall R wave in AVR. That's part of that rightward shift of the QRS. And wide QRS complexes are not quite universal, but very, very common. And also remember that these can be a cause of a really, really wide complex tachycardia. When the QRS complex is greater than 200 milliseconds, greater than one big box, lower VTAC in your differential just a little bit, not entirely, but just a little bit, and get hyper-K, metabolic, tricyclic overdose, put those up a little bit higher in your differential. And the reason why that's important is because you want to go with the sodium bicarb and even try some calcium early, because if you go straight to antiarrhythmics the way ACLS might tell you to do, you will kill that patient by abolishing their sodium channels. And again, I don't want to get too far into the toxicology aspects of this case. I would leave that to the toxicologists out there, but they did use lipid emulsion therapy in this patient, and the patient ended up surviving with a very good outcome, which is a tremendous save, not only because it was a dangerous, terrible, bad overdose and the patient was saved, but because normal treatment that most people would think of would have actually killed this patient. So kudos to Samara, Angela, and Laura on fantastic care of this patient and yet another save. So I hope that case was helpful. Again, don't forget, tricyclic overdoses, sodium channel blocker overdoses are a cause of rightward axis. And also remember, when you see really, really wide complex tachycardias, think about going with calcium and bicarb early. So I hope that case was helpful, and I look forward to talking to all of you next week. Bye for now.